In this video, we're going to go over diabetes. So let's start with the pathophysiology. So in order to understand disease pathophysiology, it's easier to first understand normal pathophysiology and how it differs. So in a normal, healthy body, insulin is produced by the pancreas. This insulin then goes and binds to insulin receptors that allows for glucose to be transported into the cell and to be used for energy. So insulin being able to bind to the receptors is essentially the key to allowing glucose to be entered into the cell. So now type 1 diabetes. Type 1 diabetes is autoimmune destruction of pancreatic beta cells that causes absolute insulin deficiency. And those are the key points right there, which then causes hyperglycemia. So essentially, this is an autoimmune disorder where the beta cells are being destroyed. Beta cells are responsible for the production of insulin. So when they are being destroyed, there is no insulin production. If there is no insulin production, then insulin cannot bind to these receptors to allow for glucose to be taken into the cell. Now, remember before I said insulin is essentially the key that allows glucose into the cell. So if we don't have insulin, we don't have a key. Type 2. Type 2 is very commonly associated with metabolic syndrome, and it causes progressive pancreatic cell destruction and insulin resistance. Now, this also causes an alteration to insulin receptors, which is what causes that insulin resistance. So, the body is still producing insulin. The insulin then travels to the receptors, but it can no longer bind to those receptors because they have been altered. Therefore, we cannot allow for glucose to be taken into the cells and used for energy. So, going back to our reference about the key, insulin is the key that allows glucose to enter into the cell to be used for energy. So, in the case of type 2 diabetes, we do have a key, but it no longer fits the lock. Now, the other problem with type 2 diabetes is Now, the other problem with type 2 diabetes is that we have an alteration in insulin receptors, but this does not stop the body from producing insulin like there is in type 1. In type 1, they do not produce insulin. In type 2, we're actually going to produce more insulin because we're trying to find the right key to fit the lock. So they're actually going to have higher levels of insulin. Whenever there are high levels of insulin being released, there are also something called amyloid proteins being released. Now, these amyloid proteins are doing more damage because they then go and continue to destroy the beta cells. So, with type 2 diabetes, if it remains uncontrolled for an extended period of time and we just chronically have high levels of insulin being released and high levels of amyloid proteins being released, we're doing a lot of damage to the beta cells, which it can eventually completely destroy the beta cells. And we will essentially turn into a type 1 diabetic where they can no longer produce insulin. All right, let's talk about some risk factors. So, risk factors for type 1 include family history, and then they also include HLA-DR3 and HLA-DR4 mutations. These are also sometimes seen in Hashimoto's and celiac disease. Now, essentially, these gene mutations make the immune system more hyperactive. So, whenever they come into contact with something, they have an increase in cytokine production and an increase in plasma cell production. This causes inappropriate antibody formation, which then go and attack the beta cells. Type 2 is very commonly associated with metabolic syndrome. So, similar things that you would see there, common in people who are obese. There is some family genetic to it, who have a sedentary lifestyle and poor diet. Presentation for both type 1 and type 2 diabetes is always going to be the standard 3 Ps: polydipsia, polyuria, and polyphagia. Now, when there are excessively high levels of glucose in the blood, this changes the osmolarity of the blood to become higher. So, the body is trying to compensate for this extra glucose. So, for polydipsia, the body is trying to dilute the blood. So, it is increasing the thirst in order to get you to drink more water to try to dilute the amount of glucose that is in the blood. Therefore, you are thirsty more often. For polyuria, the kidneys are usually responsible for filtering glucose. So the blood goes to the kidneys and it filters out the glucose so that glucose does not pass into the urine. However, when glucose is super high, the kidneys cannot reabsorb all of it. So some of it does end up spilling into the urine. Well, when the glucose spills into the urine then pulls more water because of something called osmosis. So that causes an increase in urination. And lastly, polyphagia. So, whenever the body cannot use glucose for energy because it doesn't have the insulin or the proper insulin to allow the glucose to be taken into the cell, it has to resort to burning something else for energy. So, it resorts to burning proteins and fat. So, this increases your metabolism and therefore increases your hunger. All right, there's a few different ways that we can diagnose diabetes. So, we can diagnose diabetes based off of a fasting glucose of greater than 126, a random plasma glucose, which means at any point of the day, greater than 200, along with symptoms of hyperglycemia, or the most common one that you're going to see is diagnosis through a hemoglobin A1C. Now, hemoglobin A1C measures the percentage of hemoglobin in your red blood cells that is covered with glucose. This gives us an average of about 90 days, which is why it is the most accurate form of diagnosis. Because if somebody ate something really bad over the weekend, or if they had something, really sugary for breakfast, it could potentially skew their levels just a little bit. But looking at the hemoglobin A1C gives us a really good average of a extended period of time. So we have a good idea that this is a pretty accurate reading. Now, once we have our diabetes diagnosis, we need to determine whether it's type 1 or type 2. Type 1 is more commonly found in people of a younger age, and type 2 in older age. However, type 2 is being seen more now in younger age as we have a higher obesity rate. However, age is not the only determinant to determining type 1 diabetes. We need to look at the antibodies, and we can also look at C peptide levels. So, anti GAD and anti isolate antibodies are going to be seen in type 1 diabetes, not type 2 diabetes. Because remember, type 1 is autoimmune destruction by these antibodies. So, they are going to be seen in type 1. Now, C peptide is created when insulin is created. So the pancreas makes something called proinsulin. Proinsulin then splits into insulin and C peptide. So whenever we have high levels of insulin, we have high levels of C peptide. So for type 1 diabetes, we have no insulin. So our C peptide levels are going to be low. And then in type 2 diabetes, we have high levels of insulin because remember, the insulin is not working, but that doesn't stop the body from producing it. If anything, the body is producing more of it, trying to get it to work. So higher levels of insulin would equate to high levels of C peptide. So, when it comes to management, we're only going to talk about type 2. Type 1 is pretty much going to be done by endocrinology, so this is not likely to show up on your test. So, type 2 management. For testing purposes, I want you to remember that metformin is always going to be your first line. In real life, the recommendations are first line metformin, or depending on if they have other comorbidities, you may choose to go with a different option. So, for example, if you're only doing glycemic control, metformin is definitely going to be your first line. If you want to do glycemic control and weight management, so for patients who are overweight or obese, you could consider that metformin. You could also consider a GLP-1, which are commonly going to be the most effective for that weight management, or you can consider an SGLT2. If the patient has ASCVD or they are high risk for ASCVD, you could consider a GLP-1 with CVD benefit or an SGLT2 with CVD benefit. If the patient has heart failure, you would want to consider an SGLT2 with a heart failure benefit. And if they have chronic kidney disease, you would want to consider an SGLT2 with CKD benefit or a GLP-1 with CKD benefit. So just remember, metformin test purposes is always going to be your first line, but in real practice, you're usually probably going to start with metformin, but you could also consider things based off comorbidities as well. So when it comes to monitoring the efficiency of the medications, you want to monitor the hemoglobin A1C, right? Because that's what we use to diagnose diabetes, and that's what we're going to use to kind of monitor it as well. So if they have controlled diabetes, you want to monitor their hemoglobin A1C every 6 months just to make sure it's still in well control. Now, if you are uncontrolled or if you are switching their therapy, you want to monitor every 3 months so that we can make sure that it is working properly. So hemoglobin A1C levels that you need to know. If it is less than 6.5, that is considered within normal limits. If it is less than 7, that is considered controlled. So if they have a hemoglobin A1C of 6.8, yes, they're still diabetic, of course, but that's considered controlled diabetes, and usually we're okay with that. If they have a hemoglobin A1C of greater than 7, that is considered uncontrolled and we need to do something about it. So let's say that we have a patient and we put them on metformin for their first line and they come back after 3 months and they have a hemoglobin A1C of greater than 9. That is when you are automatically going to start basal insulin. Now, what if they have a hemoglobin A1C that's greater than 7, but less than 9? So now we're going to try to put them on a second agent. So now we put them on that second agent. We have them take it for those 3 months. They come back, we draw another hemoglobin A1C. Let's say that hemoglobin A1C comes back and it's greater than 9. We're putting them on basal insulin. If it comes back greater than 7, but less than 9, we're going to put them on a third agent. Now we put them on that third agent. We keep them on it for those 3 months, have them come back. They have a hemoglobin A1C that is still greater than 7. Even if it's less than 9, at this point, we're going to put them on basal insulin. So remember that hemoglobin A1C greater than 9, regardless of how many other agents they are on, would require basal insulin. All right, there's a couple complications of diabetes that we need to understand and monitor for. So, DKA and HHS. So, when you have diabetes, with diabetes, whether type 1 or type 2, a stressor such as infection or inflammation can cause an increase in catecholamines and cortisol, which then causes an increase in gluconeogenesis, which causes an elevated glucose level. So there's DKA, which is more common in type 1 diabetics, and this has a more rapid onset. So in DKA, the body is not able to break down glucose for energy, so it starts to break down fat instead. When it breaks down this fat, this causes ketone formation, and then ketone formation leads to metabolic acidosis. The blood glucose for these patients is commonly greater than 250, and they're going to present with Kussmaul respirations, which is that fast breathing. That's the body's way of attempting to rid of that extra CO2 because of the metabolic acidosis. They're probably going to have that fruity breath, and they're going to have a high serum potassium and a low total body potassium. So the way I like to remember this is potassium follows glucose. Potassium is normally intracellular. So if there's a lot of glucose in the bloodstream, potassium is going to follow glucose out of the cell and into the bloodstream. So that serum potassium that's being drawn from the blood is high because lots of potassium is in the blood. However, total body potassium is low because where we need the potassium is empty. Now, HHS is more common in type 2, and this has a more gradual onset. This is no ketone formation because remember, in type 2 diabetes, we do still have insulin. So there is some glucose being used, and therefore, the body does not have to resort to breaking down fat for energy. Therefore, no ketones are formed. This does, however, cause extremely high levels of glucose, which then causes osmosis and extreme diuresis. These blood glucose levels are commonly higher than 600. Same thing as before, potassium follows glucose, so there's going to be high serum potassium and low total body weight potassium. And this causes an extremely high blood osmolality, which can eventually lead to encephalopathy, which we would want to monitor for changes in mental status, confusion, and level of consciousness. So those are less common complications that you're going to see in primary care, but still important to know so that you can refer if needed. More common things that you're going to see are micro and macrovascular complications. So I once heard a saying that just made so much sense. Think of glucose like shards of glass in the blood vessels. So when we have excessive amounts of glucose in the blood vessel, think of it as a bunch of tiny little shards of glass. And as they're traveling through the blood vessels, they're making tiny little cuts in the wall. Well, when you have all those tiny little cuts, eventually the blood vessels are going to start swelling because it's causing all that inflammation. So it's the same thing with all that blood glucose traveling through. It causes vascular inflammation, which then causes complications. So macrovascular complications would be things like a TIA, a stroke, or an MI because it's causing essentially atherosclerosis. Now, these things are especially Now, these complications are especially oh, what can I think? These complications are especially why can I Now, these complications are especially worse when they are in combination. Now, this is a risk for anyone with diabetes, but especially in people who have Now, these complications are a risk for anybody with diabetes. However, it is especially important to know that they are at an increased risk if they have other comorbidities that can cause this as well. Microvascular complications would be like nephropathy and retinopathy. So, with nephropathy, their chronic hyperglycemia causes glomerular sclerosis. That therefore, kidneys cannot properly filter anymore. This allows for protein to spill into the urine, the eGFR to decrease. You're going to have Okay, now let's talk about the microvascular complications, nephropathy and retinopathy. So with nephropathy, the chronic hyperglycemia causes glomerular sclerosis. This means that the kidneys can no longer filter properly. We're going to have protein spilling into the urine. We're going to have high amounts of albumin in the urine. They're at an increased risk for chronic kidney disease, and their GFR is going to be dropping. So, things that we would want to monitor for to make sure that our patients are not progressing to nephropathy are an eGFR and a urine albumin. Retinopathy, the chronic hyperglycemia, causes atherosclerosis of the retinal arteries, which can eventually lead to vision problems. So we want to recommend annual eye exams.